biggest hernia center in the United States, and the great surgeons that I have the pleasure to visit in my observership last year. Dr. Heniford and Dr. Augenstein are from the North Carolina, the Carolinas Medical Center in Charlotte. Dr. Heniford is the director of the Carolina Hernia Center. He was responsible for training and is responsible for training many recurrent hernia surgeons through his fellowship. A great skilled surgeon. I have to thank you for all that I learned from you when I was with you there. Dr. Augenstein is the professor of surgery at the Carolinas Medical Center. She is the upcoming president of the American Hernia Society, a great skilled and great mentor surgeon. And Dr. Matthew Marturano, he's the chief resident at the Atrium Health. And I have to congratulate you for your match in plastic surgery. I know that you're going to start in a few months.
Thank you.
So please, you can start your presentation.
Sure.
Thank you for coming.
Awesome. Well, thank you, everybody. Like she said, my name is Matthew Marturano, and I'm a chief resident here at Carolinas Medical Center. I've been blessed to learn from two titans of the field over the last 5 years, and what I've learned from into my plastic surgery fellowship next year. So I'm sure everyone's aware, this is a rapidly growing field, hernia, with exciting uses of technology. And I'm truly honored to be here with you guys today to be able to speak to you about something of particular interest to me. So here are our disclosures. There's no financial incentive for this talk or any study. And so for an outline of the talk, first I'm going to define the problem a little bit that we attempted to answer. Yes, we're aware of the sheer amount of incisional hernias and the exceptional cost to the medical system because of it. And then we're going to talk a little bit about what botulinum toxin actually is. You'll have to forgive me if I accidentally use one of the brand names during this presentation, as they have become pretty colloquial common. We'll talk about its indications, our injection protocol, and how it compares to the surgically advanced component separation. And then finally about the future. So two of the primary drivers of recurrence after hernia repair are wound complications and fascial dehiscence, fascial closure, excuse me. In patients with loss of domain and lateral retraction of the abdominal walls, a tension-free closure can be challenging, but failing to do so increases the risk of wound complications and hernia recurrence 3 to 5 times. In their 2016 article shown here, Dr. Holohan et al. Demonstrated that closing the fascia and avoiding bridging repair reduced surgical site occurrences, down here in the bottom table, of 0.57 and reduced recurrence rate with an odds ratio of 0.14. Further, in this 2020 paper, the Cleveland Clinic group demonstrated about a 46% hernia recurrence rate amongst their bridged patients. Within our own institutional data, amongst patients who did not get their fascia closed, we see a significant increase in wound complications, highlighted at the bottom, and a subsequent almost 7 times increase in hernia recurrence. Thus, it's clear that primary fascial closure is of utmost importance, and so we have to make a plan. And we do so prior to even stepping foot in the operating room. We start with prehabilitation and reduction of modifiable risk factors. And our preoperative optimization of these patients has continually evolved. And thus, as it is now, all patients are seen in our hernia center and evaluated by our multidisciplinary team. In addition to modifiable risk factors like smoking and glycemic control, reducing the amount of intra-abdominal and subcutaneous fat is an important aspect in the management of these hernias. And so the remaining options, of course, involve more intervention and require various levels of expertise. I'm going to discuss briefly each of these, beginning with preoperative pneumoperitoneum. It was first described in 1940, and it's really seen a large resurgence led by colleagues in Valencia, Spain, and Reims, France. Originally, the purpose was to prepare patients for the increase in intra-abdominal pressure that they will incur with the reduction of their abdominal contents. Other effects of that, however, are progressive lengthening of the lateral muscles of the abdominal wall, a theoretical decrease in visceral edema, and return of diaphragmatic tone and respiratory conditioning. Here's one of the studies published from the Reams group, and they detail their protocol, which includes prophylactic dose anticoagulation. And as you can see, there's a significant increase in intra-abdominal volume. Here are some photos from our institution. We always insert the catheter under direct laparoscopic guidance. And the reason why it's really a great and apps for this talk is that we always do it with botulinum toxin in order to maximize the lengthening of the abdominal wall. Similarly to the Reams group, we insufflate 3 times a week for 3 weeks preoperatively, and we insufflate 2 liters of CO2 at a time. We, of course, stop with any sort of shortness of breath, shoulder, or chest pain during that time. But of course, the heavy hitter of advanced surgical techniques for fascial closure is components separation. Adopted from plastic surgery, this technique was not popularized until 1990 by Ramirez, and since 2006, use of the procedure has increased substantially. When looking at different techniques, refinement of the procedure and various adjuncts has allowed advancement of the fascia with great effectiveness. But independently, component separation is known to be associated with higher wound complication rate, even with an exponential increase in technology and refinement of techniques over the years. We are deeply altering the abdominal wall musculature of the patients by making large subcutaneous skin flaps and muscular or aponeurotic lacerations. Within our institutional population of patients that underwent component separation, over 35% of patients had some sort of complication, resulting in more frequent readmission and hernia recurrence, highlighted below. So given the inherent issues with this dissection, preoperative injection of botulinum toxin has shown promising adjunctive properties in abdominal wall reconstruction because it acts as a component relaxation. We all know about botulinum toxin by its brand name, like I mentioned before. And as a reminder, the neurotoxin works by causing a functional denervation of the target tissue. But I'm a little bit of a history nerd, Dr. Heniford and Augenstein can say from my most recent grand rounds. And so I find it fascinating as to how we've gotten to headlines like I'm showing here. And so I did a little research and found that it all started with Dr. Alan Scott. He was an American ophthalmologist who wanted to treat strabismus with a simple, low-cost injection rather than conventional surgery. He used EMG-guided injection to monitor muscle activity while he was injecting. After getting FDA approval for investigational use, he began manufacturing the toxin in his lab. He injected his first strabismus patient in 1977, recorded its clinical utility, and soon had trained hundreds to inject. Now, fast forward, and obviously it's been adopted for problems with the eyes, skin, bladder, sphincter, jaw, migraines, etc., and in clinical trials to treat a myriad of other conditions. To quantify this explosion, in 1981, the botulinum toxin market was $9 million, and in 2019, it reached $3.2 billion. Here's a little bit of a basic science diagram to remind us of its mechanism and action without getting too much in depth. The toxin is absorbed into the neuromuscular end plate by endocytosis. It cleaves vital proteins and inhibits the ability to release the neurotransmitter acetylcholine, which causes a flaccid paralysis of the target muscles. Now, when we go back to clinical, which is what we're here talking about, our colleagues in Guadalajara were the first to investigate its use in abdominal wall laxity. Here's an article that demonstrates this very well. Its preoperative injection allows the muscles of the abdominal wall to elongate and become more compliant. This is particularly useful in patients with large hernias and loss of domain. Their group measured the abdominal wall muscular both pre and post-injection and clearly demonstrated significant lengthening and thinning of the muscles of their patient. And in doing so, it causes the defects to shrink, as you can see as well. This is a study from the same group that radiographically shows the same findings. Using CT scans, we're able to demonstrate that there is an increase in lateral muscle length with toxin injection. In this study, a mean gain of 4.2 centimeters on either side for a total of 8.4 centimeters total. They saw a reduction in defect size of up to 58% in this study, and no recurrences were seen with mean follow-up 16 months. And so who do we use the toxin on? That's really the question we've started to try to answer with this paper. And since it's been used as an adjunct is fairly recent, there's not really a consensus on how to select patients that will benefit. When selecting patients, it's important to consider not only their hernia defect size, but loss of domain, location, and proximity to bony structures as well. Generally, botulinum toxin use is indicated for wider hernias with loss of domain, which require increased laxity in order to get fascial closure. In addition, patients lower on the abdominal wall see the biggest benefit because M1 hernias, as shown on this cartoon sideways, are more likely to be bound laterally by the intercostal muscles, making it more difficult to achieve fascial closure and needing that laceration to be able to bring the edges closed. And so there are a limited number of contraindications listed here. Mostly these are limited to patients with existing neuromuscular disorders and pre-existing neuropathies. However, there are some case studies in China in which patients were still able to get the toxin. In all reported studies, injection in the abdominal wall was found to be safe with no major complications and only a small number of minor complications in the literature. And so the timing of injection is essential. Botulinum toxin is injected at least 2 weeks prior to scheduled surgery, most often between 2 and 4 weeks. As you can see in this study of almost 200 consecutive patients, the average time to onset of the toxin was approximately 6.2 days and lasts almost 80 days. By injecting it at least 2 weeks preoperatively, it provides ample time for effect and to have maximal benefit for the patient. After 1 month, the effects begin to subside. Of course, there are instances in which patient surgeries get delayed, and one of the benefits of using botulinum toxin preoperatively is that it is repeatable without any described adverse effects in the literature. The way that we do the injections, our protocol rather, is patients are taken to radiology and placed supine. Injections are placed with ultrasound or CT guidance. In our experience, the majority of patients do fine with this without any sort of pre-medication needed. Our injections consist of 200 units of the toxin diluted in 100 cc's of saline. This is then divided into 12 separate syringes, 2 at each of these locations seen here on this cartoon. At each location, the needle is directed towards the internal oblique muscle, where the initial injection is performed with the entire volume of the syringe. The needle is then retracted into the external oblique for another syringe injection. And then the sites are dressed with gauze in an occlusive dressing, and the patient is sent home until surgery. So I have a video here. Let's see if it'll be able to play of one of our radiologists injecting. Is everybody able to see that?
Absolutely.
Excellent. As you can see, those are the layers of the abdominal wall there on ultrasound. He's advancing the spinal needle into the external oblique muscle, as you can see, and then inserting the bolus of the syringe. This table here describes the published botulinum toxin injection protocols as of 2021. I know it's a little bit hard to see. There's a lot of information here, but there's a lot of different protocols, and most of them inject all 3 layers of the abdominal wall. One of our previous fellows, Dr. Eva Dierenberg, published a paper in the Journal of Surgical Research that encapsulated the entirety of our cohorts to that point. When we started, we were injecting all 3 layers of the abdominal wall. However, we soon switched to only 2, and that's for multiple reasons. First, In these patients with large loss of domain, the transversus abdominis is often thin and difficult to really inject. Second, there's a historic concern for truncal instability if you flaccidly paralyze all 3 layers of the abdominal wall. Although within our cohort, we never saw any complications like this. And then third, there's less cost with only 2-layer injections. And then finally, there's no difference in outcomes, and that's really where it comes down to, with lengthening or achieving primary fascial closure with only doing 2-layer injections. And so the natural question was, given that component separation is associated with increased wound complications, is there a subset of patients in which component separation can be eliminated entirely, but still perform a durable repair? With that in mind, our goal was to compare outcomes between patients who get component separation alone and those who undergo preoperative botulinum injection alone in abdominal wall reconstruction. We anticipated that recurrence rates and surgical site occurrences would be comparable with the 2 techniques. So over a 5-year period, we used our own single institution prospectively collected database to examine patients that received botulinum toxin prior to ventral hernia repair. Since these patients are so heterogeneous, we performed a 3-to-1 propensity match with the listed criteria here. Hernias were measured and evaluated by their European Hernia Society classification to help us identify the location on the abdominal wall. The algorithm for performing component separation was defined by length of release needed to achieve fascial closure. Although abdominal wall compliance is different for every patient, we frequently remeasure the remnant defect and only cut as many fascial and muscular layers as is necessary to get the midline reapproximated. In all, patient characteristics were similar between the 2 groups, as you can see. The top 3 characteristics here really demonstrate that these patients are highly comorbid. And then the bottom 3 here are the hernia factors. And the important things, really all of them are, but there you can see there was 5 failed hernia repairs each. Their defect sizes were large and well matched. And of note, the botulinum group had almost 3 liters in their hernia volume. This graph here uses the European Hernia Society criteria to show where on the abdominal wall the hernia components were located. Clearly, there's more frequent M1 hernias within the component separation group as expected. And then this graph shows a breakdown of component separation techniques within the cohort. 54% underwent a posterior release, 24% an anterior, and 21% an anterior on one side and a posterior on the other side. And so when comparing operative characteristics of both groups, patients had a similar mesh size, composition, and placement location. Fascial closure occurred at a high rate in both groups, and there was no difference in operative times or paniculectomy rates between the groups. Of note, the delayed primary closure occurred more frequently in the botulinum group. And then these are our postoperative complications. Between the 2 groups, there were more surgical site occurrences and infection in the component separation group when compared to the botulinum group. This was not reflected in the length of stay increase as the difference was not significant. We then did a subgroup analysis to exclude the delayed primary closure. There was no difference in hernia recurrence or infection, yet there remains more surgical site occurrences within the component separation group. Additionally, although not statistically significant, hernia recurrence rate was over 3 times as high within the component separation group, and lack of statistical significance could be a beta error. We also did another subgroup analysis to exclude anterior component separation, the one with the biggest cutaneous flaps. Again, there remains a difference in surgical site occurrences without one in recurrence or infection rate. And so that leads us to confirm our initial hypothesis. So there are a subset of patients in which botulinum toxin without component separation can assist with a durable hernia repair without increasing surgical site occurrence and infection rates. And so what do we do with this data? When we look at the future, it may be possible to determine the subset of patients preoperatively who could be spared from component separation. The question is, how can we develop a better understanding of patients who may optimally benefit from botulinum injection? Our institution has been working with artificial intelligence to develop models to predict these types of surgical outcomes. In this study, AI was used to predict surgical complexity to better counsel patients. And then in this one, we have a second model that's able to predict rare outcomes. In this study, the use of component separation was used as a surrogate for surgical complexity. As we refine the model, our hope would be that we would be able to anticipate which patients would not require component separation for fascial closure. In fact, at our institution, despite a nationwide increase in component separation, we've demonstrated a 35% reduction following the introduction of a botulinum toxin. And this has also been associated with decreased wound morbidity and length of stay. This is data that I just mentioned is being presented at the American College of Surgeons at their upcoming meeting. And so I want to thank the Brazilian Hernia Society for allowing me to talk. That kind of comes to the end of my talk. I'm happy to answer any questions. I truly am honored for being able to be invited to this. Thank you.
Thank you, Matt. Is a big pleasure for us this discussions here, because for us in Brazil is a very expensive. The Botox have many groups in Brazil use the Botox, and other groups is just performs through separation componation. Natalia, to start the talk, the discussion.
Oh yeah, so sorry guys, my microphone, I had a problem here. I'm trying to connect with my cell phone.
We can hear you well.
Yeah, you're all good.
Okay. Great discussion. Congratulations, Matt, Todd, and Dr. Heniford and Dr. Augenstein. The great work. It's a very heterogeneous kind of patients. You have to analyze. And I know that you told Matthew that you don't have a protocol, but can you explain to us how do you select the patients? Is about the hernia size, the BMI? How do you select the patients to do the Botox?
Yeah, so I think originally when the technology was introduced, the Botox was really used for the worst of the worst hernias. Dr. Heniford and Augenstein can kind of correct me if I'm wrong, but as we started using it and seeing how much advancement we really were able to get, we started to refine it towards more patients with large loss of domain that kind of fit that criteria, that of the lower abdominal wall, large loss of domain, large defects. Dr. Heniford, is there anything that I'm missing there?
You're absolutely correct. When we first started doing it, we used it in the worst patients, and I think about 40% of those patients had fistulas or mesh infections. The contamination rate overall was about 70%, and so big defects with contaminated cases, and we wanted to use it, and so we didn't want to make skin flaps in those patients, these contaminated cases. So initially, it was in an effort to decrease wound-related complications, and then we were successful enough with that we now what we've tried to do is exactly what Matt has discussed. Is we try not to do component separation. We do a pre-peritoneal dissection, open and even robotically or laparoscopically, and we do our best to leave the abdominal wall intact. And so the much like the things that Matt said about, Botox is a tool for us to use along with weight loss and along with component separation and pneumoperitoneum and hopefully fasciotins in the future.
Thank you so much. So we are.
I have one question. The Cleveland Clinic group to demonstration the aspect for the sections and the pressure for the first line. The article explained the idea that the transaction for transversal abdominal, the transversal muscle is not to increase the pressure in the abdominal. The question is, do you think the Botox would help in a case of the bridge mesh after the component separation?
I think it's reasonable if you think about the physiology of just the pressure. However, I think that where the bridge mesh breaks down and fails is more long-term, and the Botox by definition is a temporary measure. And so I wonder if what we would see is recurrences, maybe even just delayed, but with its use.
It's also interesting. I think if you think about wound healing, and there's a study, a very nice study that was looking at abdominal walls and predicting hernias in patients, and this was performed in the Netherlands by Hans Jekyll. And so they ultrasounded laparotomy closures, and what they saw is most of the patients who developed a hernia developed separation fairly early, within the first 6 weeks or so after surgery. And it's interesting, when you use Botox in the abdominal wall, you'll see a patient 2 weeks after surgery and their abdomen has expanded. The obliques, you put the obliques under tension and they'll expand. And so people look kind of bloated, look full. And then it's like a party trick, and several weeks after that, they tighten right back up again. And so it would be interesting to see if that actually takes tension off of your wound closure. And so that in and of itself may actually make a primary closure of a ventral hernia actually perhaps work better, or in a large laparotomy decrease the hernia rate. And Vedra, Matt, do you have anything? What do you think, your thoughts about that?
I was just going to mention one thing that Matt already talked about a little bit, the M1 and like the M5 hernias, so talking about Dr. Pereira's question of what are the good indications? If you see somebody in the office and they have a really big subxiphoid hernia or a big suprapubic hernia, you can inject Botox, but it's probably not going to be that helpful. It works best for the hernias that are mostly like in the middle of the abdomen, just because the bottom and the top, they have like the costal margin and they have the pelvis. So those are kind of the tougher hernias, but it's not going to hurt, to inject it. It's just that you may need other things as well, like a paniculectomy and a lot of subcu dissection and external oblique. So I think those are some of the things to just kind of keep in mind, because it's not magic. And then the other thing is that if a patient has a lot of fibrosis in the abdominal wall, if they have like a really big mesh, like a big Marlix in the abdominal wall, even if you inject Botox, it's probably not going to work as well. So, I mean, it really kind of varies on certain individuals. And of course, who's injecting, I think that's really important. We've had the same guys injecting patients for over 10 years now. So I think they've gotten really good at it. But you just wonder, if there are people doing it for the first time, if you're going to get the same effect.
To kind of go off what Dr. Heniford said too, I think that there is a lot of, or there would be utility for a primary laparotomy, an index laparotomy using Botox injections. However, the reality of that study, as was mentioned before, it's already extremely expensive, it's off-label, it's hard to get insurance to cover it. In patients who have incredibly complex hernias, as shown by Dr. Heniford, finding somebody with an index as a prophylactic type of measure, I think, would be even harder.
Any questions, Diego, our Brazilian American citizen?
No, I just wanted to congratulate you guys. I think the methodology of this study is pretty elegant. I like propensity score matching. I know there are big discussions regarding doing either a multivariate logistic regression or just PSM. And I know that the PSM has a logistic regression on it. And I know that the papers, the journals have been asking more frequently for PSM, because you can have two cohorts that are kind of similar and you kind of achieve these in a very heterogeneous population. So I think the results are very interesting. And I don't know if you guys are going to remember, I asked you guys for a video about this paper for the Surgery Journal months ago. And I just wanted to congratulate you guys for this project. And it's pretty interesting.
Any other questions, guys?
So I'll ask one, Vedra. If you
Oh.
had to dial in a new Botox, a new drug, and that will cause muscle paralysis, how quick would you want it to work, and how long would you have it work?
Well, I think it would be awesome for it to work right away, so we can maybe use it in like open abdomen, like in trauma set, or not trauma, but acute surgery. So you could immediately, and I don't know that it would work right away, but yeah, if it could work right away, it would be great. And you know, I think 6 to 8 weeks, like we always tell patients 6 to 8 weeks, and then you can go back to normal activity, because we all kind of believe that that fascia is healed at that point. So I don't know that you necessarily need 4 months that we have right now. So it can go away a little bit sooner, but it doesn't hurt if it hangs around longer. You always ask questions that you have answers to, so I'm curious what you and everybody else thinks.
Listen, I steal as many of your ideas as I possibly can.
I have a question about the preperitoneal technique, because I saw you do a very elegant dissection in the preperitoneal plane, even in the recurrent hernias. But maybe sometimes this is difficult to do, and I'd like to know if you have some technical tips to the young surgeons, how to perform this dissection without making a lot of holes in the preperitoneum. And if you make holes, how do you fix it when the suture is not sufficient to close the peritoneum? Can be for all of you, okay?
No, that's your technique. You talk
Go ahead,
about
Vedra.
your technique. Because I learned the technique from Todd, but it is really something he's developed, and you know, people are. I think we're going to be doing a lot more preperitoneal repairs. I really think the benefit is that you don't have to do a TAR, and you're still getting that same preperitoneal layer. You're not in a lot of patients don't need any kind of component separation. So I'm just teeing you up, but Todd, you tell us about how you invented it, and you know, really some of these techniques.
Well, we started just because often doing a rectus rectus repair, we were not satisfied. The overlap would be someone would have a fairly narrow rectus muscle, and 4 or 5 centimeters. I just wasn't. I didn't like that. And the more complex hernias we saw, the more overlap I wanted. And indeed, the more overlap we have demonstrated, we reduce the recurrence rate. So bigger meshes do not increase the risk of infection. Bigger meshes do not increase the risk of other complications or impact quality of life, but they decrease recurrence. And so when we start, typically we'll start in the space of retius, or we'll start at the falciform. When you start in the space of retius, and anyone in this call has probably been in that space many times, laparoscopically doing inguinal hernia repairs. But it's that familiarity really helps someone develop that plane, come out wide, right on the pubic bone, just break into the space of Bogros. And then for the most part, if you've taken the adhesions down off of the abdominal wall, no interloop adhesiolysis, just take the adhesions down off the abdominal wall. When you go really far lateral, and then peel the peritoneum back to the wound. And so most often you can peel the peritoneum back to the wound. Sometimes we'll get into take transversalis fascia down and leave the transversus abdominis muscle up. So you can stay not only just preperitoneal, but pretransversalis if you want. And then also we'll take bits and portions of the rectus fascia, posterior rectus fascia if we need to. But usually you can walk that up the abdomen. The peritoneum gets, the area where the fat is. So lateral abdominal wall, under the xiphoid, at the pubis, are the easiest places to do this, and then peel it back to the wound, and then you can just go as far lateral and posterior as you want, and if you can't get the peritoneum together, then just go further lateral. Just like with a TAR, you can just keep going lateral and pull that posterior elements together. The other consideration is just if you have an opening, just suture the omentum in the middle of it. That was actually described by Reeves. First described by Reeves 40 years ago, and when you couldn't get the posterior rectus sheath together for a rectus rectus repair. And then the other thing is we don't cut the hernia sac off. And so until the very end of the operation, you can always defat the hernia sac and just lay that over an opening in the peritoneum and just whip stitch it with an absorbable suture.
Thank you, Dr. Heniford. Great explanation.
You're welcome.
Alvaro, you'd like to, do you have a question?
I'm sorry for the late entering of the session. I am just getting out of hospital. Maybe that's because of the noise. Can you hear me clearly? Hello?
We are hearing you.
Oh, I really enjoyed reading the text. I'd like to thank the opportunity to speak to you all, guys. But I have some questions regarding the patient selection. In the manuscript you use for the selection of the patients and the comparison between the two groups, for midline incisional hernia, for the location, you use the European Hernia Society classification, but you guys choose to use the area of the defects regarding for comparison between the groups. I'd like to ask why you chose for this kind of operation.
Matt? I think you're muted.
I'm just going to repeat the question so so that I understand what the question is. The question is, why use the European Hernia Society classification for patient selection when we use hernia defect size as a matching criteria? Is that correct?
Yeah, but you use the area of the defect on the selection and not the usual W1 and 2 and 3.
Yeah, I think that, Dr. Heniford can jump in here at any time. I think that the importance of these hernias is they are so complex, and using the European Hernia Society classification was just components of this massive complex hernia. And so kind of going from a similarity with the propensity match, having patients with large areas, I think encapsulated a better picture of what the patient's hernias actually were, as opposed to just isolating just M1s or just M2s, just because the components are so large.
Yeah, we had divided. We had to decide it's either going to be size or it's going to be location. And so most people look at the size of the defect, and in all the previous papers, it's when it was measured, it's about how much smaller the defect was. Nobody's really, until Eva Derenberg published it, no one really talked about M1 hernias being difficult with Botox and requiring more component separations.
Matthew, I have one question. Professor Latifa asked you about transplant patients. Do you think Botox is appropriated to use in transplant patients?
If the concern is for immunosuppressed patients, I think that I haven't seen any sort of data to show that would not be appropriate for them. I think that certainly you'd have to use it with caution. If you're referring to the type of hernias, I think that absolutely Botox would be a wonderful use for these complex Mikuchi subcostal type of incisions, especially since those types of incisions tend to have abnormal tension instead of a symmetrical tension from a midline incision.
Yes.
All right. I have a question. It's not about the work specifically, your paper specifically, but when I was at Carolinas, I saw you using a lot of the vacuum system on the wounds, not only for contaminate field. When you close the suture, the skin, you place this vacuum system. What do you do that, and what's the advantage of using these for dressing?
Yeah, so that's a good question, Dr. Pereira. And actually, so we do a lot of paniculectomies with our some of our ventral hernias. I think like we do some hernias robotically. well, it's either robotically or maybe very few laparoscopically, and then the rest of them are open. When they're open, we often combine with a penniculectomy because a lot of these patients have a lot of excess skin that needs to get resected at the same time. So doing these penniculectomies, Todd started doing these with a plastic surgeon many, many years ago. And they were not that dressing that you're referring to, the incisional, the negative incisional pressure therapy. It wasn't available, you know, until, I don't know, maybe 5-6 years ago, and we weren't using it. It wasn't available to us. And I even remember as a resident making fun of it because I thought, well, you know, you're closing the incision. Why are you going to put a wound back on the closed incision? It makes no sense. And the infection rate for these penniculectomies, our wound infection rate was very high. With the penniculectomies, when you combine it, it was something like 30%. Since we have started doing this negative incisional therapy, it's dropped way lower, you know, well below 10%. So it's really a huge dramatic difference. And you know, if you can prevent these wound complications, then you're also helping these patients not get hernia recurrences. And compared to how much some of the other stuff costs in the operating room, it's pretty inexpensive. Like the big customizable ones that are 125 centimeters are actually, it's about a $200 to $300 dressing, which is nothing compared to, you know, the mesh and the suture and everything else that we're using in the operating room. And the patients will wear it for about 8 days, take that dressing off. It's impregnated with silver. And even though it looks like it's compressive, it's actually negative pressure. So it's kind of lifting up on the wound and allowing for perfusion. So there've actually been a lot of some plastic surgery studies actually looking where they've put the incisional vac on one part of the incision and didn't put anything on the other side. And then they use like fluorescent imaging, like the indicyanine green, and they could see that you have more perfusion where you have this incisional vac. And it's basically because it's lifting on the incision. So I don't know if you guys have that available. I know there are a lot of ways you can make vacs. Before I got the actual product that we use right now, I used to make my own, and I'm a huge believer in it. I mean, it's really, I remember how many wounds we used to open in clinic and how very few we open now. Maybe Todd and Matt, you guys can also talk about it.
Yeah, I think I don't have the data in front of me about but you know, with these patients, it's so clearly associated with wound complications is so clearly associated with recurrences and other complications and morbidity. And so I think that anything that we can do to reduce that, I think is valuable. What Dr. Augenstein is referring to with the VAC, I think is awesome. The product that we have has a self-contained motor that will just turn off in 8 days. And so patients can go home with that when they are ready. And then I'll just turn off on its own, and then the patient just removes the bandage or the dressing and throws it in the trash, which I think is a very you know, empowering thing for the patient too. And then one thing that I've also heard is that the benefit of it is that the surgery team doesn't have to look at the wound for 7 days.
That's nice. Thank you.
But then
You
they
have
have
something?
to remove the dressing later.
Yeah.
Right? I have a couple questions for you. So you guys did a retrospective study in a prospective collect data. Are you thinking about doing a trial on this? Or in the second question is this covered by insurance or not really? What are the challenges that you face to use the Botox?
Yeah, I mean, Allergan is going to be doing a randomized controlled trial. You know, they're going to be accruing patients and all of that. So that's not quite out yet. But as far as there are a lot of challenges, it's very expensive in the US as well. I think for these patients, it's about $3,000 for just one patient, you know, because it's about, you know, 200-300 units that get injected. So it is a lot. We're having more trouble now getting it approved than in the past. And I think until it's approved by the Federal Drug Administration, FDA here, it's still considered off-label. And this is another reason insurance is denying it, just because they like to deny everything, like, you know, that helps.
About 20% of the patients I operate on now get Botox, have had Botox. And so we still get it through, but as Vedra said, we have to make a lot more phone calls to the insurance company and that sort of thing.
And I do think that I'm a believer, I'm sure that everybody else is, because all the other adjuncts that we have here would work wonderfully in concert with using Botox too. Dr. Heniford mentioned the fasciotens, which acts purely by stretching in an anterior plane the fascia. With the addition of Botox, you're just going to multiply the benefit of doing something like that.
I agree with you, Matt.
Any other questions?
I have one question. The target for this paper is the outcomes about the operative wound outcomes. Could a minimal invasive performance better, in your opinion?
For wound complications?
Yes, wound complications.
Yeah, so we will do minimally invasive, we will do robotic ventral hernia repairs in the appropriate patient. And if you want the ultimate way to decrease wound-related complications, it's that. But there are many patients who especially with our practice, that just are not, we just really can't do them robotically or laparoscopically. As Matt mentioned in this study, the average number of previous hernia repairs was 5 failed hernia repairs in these patients. And so that gets pretty challenging robotically. The average defect was about 240 square centimeters. And then in the Botox group, it was, 2 liters?
Almost 3.
Almost 3 liters of hernia volume. So these are massive, multiple recurrent hernias. And in those patients, and Vedra's right, if we develop a wound infection, our failure rate's 3.1 times higher. If we don't get the fascia together, it's 7 times higher. And so, if you can do these things robotically or laparoscopically, you tend to you get away from wound complications and the expensive wound complications and the like. And Vedra's led our robotic ventral hernia repair stuff for years here, but a lot of patients just don't qualify.
I was going to say, you are seeing some people who are doing these hybrid procedures, and we really don't do that because honestly, like people will tell you, oh, you can still do everything minimally invasive, and then you just, cut all the skin off later, and that's okay. It makes absolutely no sense, and there's absolutely no data on it. Nobody's ever published anything to say that your rate of infection is like minimally invasive surgery if you do hybrid. If you're making an incision that's a foot long, that's the wound morbidities from that foot long incision. So if you have somebody that really needs Botox to get their hernia fixed, there's going to be a lot of skin to resect because it's a big hernia defect. You close the fascia, there's going to be all the skin that you need to resect. And if you're going to, and some people say that, I'm more comfortable doing robotic, TARs and things like that. But Natalia has been in our OR and we do this stuff very quickly as far as the preperitoneal dissection and the paniculectomy and everything. I think minimally invasive procedures, I think they're great for appropriate defects. I don't know that with Botox, that it's going to be a big deal. I wonder, this is one thing I've always wondered, if we can, for smaller hernias, if we can just inject Botox and do these minimally invasive and not even use a mesh, because that's the question, the critical time of healing, you got 4 months or 3 or 4 months of relaxation. Do we even need mesh? If you're a healthy woman, you got about a 3 centimeter hernia, you just have somebody inject Botox and you say, well, let's try this. If it comes back, fix it robotically. Why not? So anyway, I have no data on that either, but if somebody wants to study it, it'd be a good one.
The question is because in Brazil it's more easy to use the robot than you use the Botox.
Interesting. It's easier.
Yeah, for us it's very expensive.
Yeah, it's easier to use a $2.1 million robot than Botox.
Yeah, that's the question. So in your paper, you compare, you put just a graphic comparing the ideal patients. And in the ideal patients that doesn't have diabetes, doesn't smoke, it seems that the surgical site infection and the surgical site occurrence is the same in the group of the Botox. and the component separation. I don't know if I'm wrong or this is right in the paper.
Go ahead.
Yeah, I think
The question is if the more morbidity obese patients and diabetics, you can mix the data, like confuse the outcomes with these patients, because you put the ideal patient there that doesn't have the same side, like the Botox is the same of the component separation in the ideal patient, but it's not when you have this very complex patient with high BMI and diabetes and other comorbidities. I don't know if you have some.
Well, they were compared. I mean, they were paired very closely. So the diabetics were equal in each group. Smoking was equal in each group, and in the body mass index was extremely close. So yeah, this is, and as when Matt started this presentation and mentioned this, these are very heterogeneous patients. You know, you get where the hernia is located, how many repairs they've had, previous surgeries they've had, you know, the quality of the skin. I mean, these are really different patients, one to the next. So when you do this propensity match study, you just have to compare them as closely as you can.
I have a different question. If you are in a perfect weather and the patient's all ideal, which you prefer, Botox or component separation?
Botox.
Correct. Botox.
Botox and preperitoneal. Big mash with preperitoneal and Botox. Yeah.
Yeah,
Matthew.
it's all part of the tool set, you know. I think that's like some of these big hernias, we're thinking at first we're gonna probably have to do Botox and component separation. But then if you really get a good response from the Botox, or maybe you did the panniculectomy, so now all that muscle is really released, and then it's great. You didn't have to do a component separation. So it's, yeah.
Do you think that the use of facial things will be helpful in these patients with Botox? We don't have here in Brazil because the Anvisa don't approve.
They're doing a prospective trial now in Hamburg, in Berlin, and the person who's running that trial, I asked him exactly that question 2 weeks ago, and he said that he believed that Botox helps fasciotens. He's got previous data that fasciotens is very helpful, but he believes the combination is even better, much like what Matt described.
All right. Any other questions, guys?
May I?
Do you have any other question?
Just a comment.
Hi,
Sorry,
Gustavo.
I'm late. I'm late, but in the end, I will do the proper a couple words. But
I introduced you. The Gustavo
okay.
Soares is a president for Brazilian Hernia Society. He uses Botox a lot. He don't have a robot.
Yeah, I am a Botox fan. It's a great tool. I'm sure about it. And thank you, everyone, to be here. It's a very important for us, this kind of event. And in the end, I will do I will say some words. But the comment is, in the future, do you think, Todd, Vedra, Matthew, in the future, we can dream with a scenario where we have to use in every case the Botox before the component separation technique? Because in my thoughts, I think the goal is reduce or decrease the intra-abdominal pressure after the abdominal repair or close the midline. And the Botox has this power. It's a good tool to do this, and the costs for the patient and sometimes for the insurance, the cost is less than the cost of the component separation technique. I think if I are able to see the future, I think in the future we'll be able just do component separation before and after the use of Botox. What do you think about it?
Yeah, I agree. The cost to the patient, if you're the patient, the cost of a component separation is great because you're cutting fascia, you're cutting muscle, and the cost of Botox, it's, whatever the money is, but honestly, surgery itself is very expensive. So I think it's kind of like when people are paying for plastic surgery. I mean, it is, I think it's really important to, think about it that way, because I think there is a cost to doing a TAR. I think, we talk about and we say it's no big deal because we're talking about the person who has a hernia and now is repaired, and you're comparing them to their previous hernia state. But if you're talking to somebody who had a hernia and now has his abdominal wall completely put back together, but has not had any kind of fascial separation or muscle cut, I think that person's probably going to be better.
I believe what you believe. I think that, and I'll say that.
Good.
Yeah, but I'll say that it's good to see you again. I think it's in our institution. I tell my kids, it's not what you tell me. You vote with your feet. And it's what you do. And so we get paid more. I mean, we get paid as surgeons. We get paid more if we do a component separation. And but Vedra and I have tried to eliminate component separation. We'll make it, and it actually costs us time. Because we have to talk, we have to write a letter to the insurance company, we have to call the insurance company, and then we don't do a component separation. So we cost more time and we don't make as much money. But we think it's the right thing to do. And in our algorithm, it's weight loss, Botox, component separation to take care of these patients. And we want to keep both. We've done hundreds of component separations. We keep component separation on the bench. Now when we're ready to pull it out, we're ready to pull it out, and we'll do it. But yeah, I agree with you, and we're voting with our feet.
Nice. Guys, we are in our time. So if you have another question for Dr. Augenstein, Dr. Heniford, or Dr. Marturano, please, this is the time. So I think this is the end of our meeting. I want to thank you so much. It's a truly honor to have the greatest centers, hernia centers in the United States here with us, join the Brazilian Hernia Society meeting. It's a great honor to have you. We respect you as the best hernia surgeons in the world. This is so huge for us. So thank you so much for your time. Thank you, Matthew, for the brilliant presentation. Vedra, my admiration for you forever. You are a great mentor. Todd, you are one of the father of the hernia in the world. So I would pass the word for our president, Gustavo, just to the final words. Thank you so much for your time here.
Okay, thank you, everyone. Todd Heniford, as I saw in the last Brazilian Congress, Hernia Congress. Thank you so much. This kind of event, it's so important for us. I think the Brazil and United States, we are in so many aspects, we are very similar. We learn a lot with you, and nice to see you. And our team from SBH, I think, guys, you are doing a great job. Thank you again, and I hope see everyone in person. Thank you so much.
Thanks for having us. Really appreciate it very much.
Thanks for the opportunity, guys.
Thank you.
Thanks.
Thank you, everyone. See you.
All right, bye-bye.
Bye
See you.
bye. Have
Bye-bye.
a great night.
Bye-bye.
Bye-bye.